non-pharmacological interventions for sleep. Today marks a shift from diagnostics to a more holistic and integrative approach to sleep health as we explore the role of yoga in sleep and well-being through practical sessions.
From mindful breathing to therapeutic postures, today's session will help us connect mind and body and explore evidence based yoga practices that can support sleep health and overall wellness.
We begin our day with deeply relevant topics led by our esteemed speakers Dr. Christina Franz Ma'am and Professor Manjari Tripathi, a distinguished neurologist and academician from All India Institute of Medical Sciences. We begin with a lecture where we will be exploring the intricate world of sleep respiratory disorders, both central and obstructive sleep apnea. This session, led by Dr. Christina Franz Ma'am, will delve into the theoretical foundation, assessment tools, and non pharmacological treatments, followed by a clinical case discussion. Please join me in welcoming our esteemed speaker, Dr. Christina Franz Ma'am.
I can do it. I'll try to do it. Good morning, everyone. So, today we are speaking about the sleep breathing disorders. Um, there are a lot of diseases in this group of sleep disorders. There are sleep-related hypoxemia, hypoventilation. There are also isolated symptoms like primary snoring. But today, we are focusing on obstructive and central sleep apnea. So just to make it very, very precise from what I said yesterday, I just inserted these two next slides so you have the picture here. We can see the airflow and the respiratory effort. In an obstructive event, we have no airflow, but we do have a respiratory effort. This is the main feature that differentiates obstructive from central. In the central one, we still have no airflow, but we have no respiratory effort. And how things look like. So if we see here, we have an event type. So this is the picture of a normal breathing. This is the airway cross-sectional area, okay? So we see it here in this perspective. And here we see that the flow in these blue arrows, it goes through the airway. So here we have the muscles and the flows go smoothly into the airway. We have this inspiratory flow shape of an obstructed flow. And in the flow analysis, that is something that we are not having in this course, but is something that we do daily on clinical practice, is this flow curve analysis. Okay, so the curve will look like this thing here. So this is the picture of a normal breathing. What happens when I have flow limitation? Just like you asked yesterday, snoring, for example, is a kind of flow limitation. So you see that if we compare with normal breathing, there is a reduced airway cross-sectional area. We have a partially obstructed way. We see a flattening of this curve. And you see that this flow limitation happens here. We see it. It does not go smoothly. It goes like in square things all the time. So this is when we have flow limitation. Now, When we have an hypopnea, we have even smaller airway cross-sectional, even smaller way for the air to pass through. So you see here, maybe these are the muscles, but we have an increasingly obstructed airway. We have a longer flattening and further reduced flow. And the flow curve will look like this here. In the apnea event per se, we have a reduction in the airflow of 90% of the baseline that lasts at least for 10 seconds. And we have a completely obstructed airway, so the air doesn't pass through. The inspiratory flow shape is minimal. You have no flow here. So this looks like a line. And the event will look like this when we have the flow analysis. So I think this is a very nice picture. You can take photos if you want, because it's very didactic and it explains the whole spectrum of the obstructive apneas compared to a normal breathing. So let's delve deep into OSA. OSA is, here again, you have a normal airway, and then you have the hypopnea, a partially obstructed airway. Then you have a completely airway obstruction here. And that, both of them, they lead to an arousal because of the decrease in good oxygen saturation. So this is kind of something that our body does for maintaining us alive, of course. So obstructive sleep apnea is characterized by repeated frequent episodes of complete or partial airway obstruction during sleep. The diagnostic criteria by the American Academy of Sleep Medicine and the International Classification of Sleep Disorders must have these two, A and B. So in the A, we need the presence of one or more of the following: a complaint by the patient of sleepiness, non-restorative sleep, fatigue, or any other sleep symptom. The patient sometimes wakes with breath holding, gasping, choking. The bed partner usually observes snoring or breathing interruptions or both during sleep. The patient might have a diagnosis of hypertension or mood disorder, cognitive dysfunction, any heart or brain diseases, and type 2 diabetes. And the diagnosis requires a kind of objective examination. The gold standard that we set tomorrow is the polysomnography, but sometimes we don't have the polysomnography, so we can have the portable devices, okay? But again, diagnosis made by a physician. So here we have the cessation of the airflow for 10 seconds, and we still have movement in the thoracic and abdominal belts. So obstructive sleep apnea is usually terminated by an arousal or is associated of desaturation. We have some rules to score that. So for hypopnea, for example, there must be a snoring during an event. There is an increased respiratory flattening that we can see of the flow sign compared to the baseline breathing. Here we see the snoring, okay? there is a drop in saturation, and this is associated with thoracoabdominal paradox movements during the event, but not during the pre-event breathing. We have two rules to score hypopnea. The first one, the peak excursions drop by 30% of pre-event baseline. And the second one, the duration of the increase, a 3% drop in the signal is more than 10 seconds. We have a 3% oxygen desaturation from pre-event baseline, or the event is associated with an arousal. The second rule are the same things, but there is a 4% desaturation of oxygen from pre-event baseline. So these two rules are applied daily on PSG. We also have what we call respiratory effort-related arousal. That is not apnea, it's not hypopnea. It has no criteria to be diagnosed as apnea or hypopnea. It's a low feature. So it has no criteria to be scored as apnea or hypopnea, but it leads to an arousal from sleep. The duration needs to last more than 10 seconds, and this is an increasing respiratory effort or flattening of the inspiratory portion of the throat, followed by an arousal. So yesterday, I told you that sometimes in the titration studies, we have a pressure, and remember that I told you that I used to have the lowest ones, and then I saw that this rhythm was appearing, so I had to increase the pressure. So this is like a tricky thing. We have to look to all these variables all the time. We also have a mixed component of obstructive sleep apnea. That is, we have the both components, obstructive and central ones, with each one lasting at least one normal respiratory breathing cycle. So if we see here, we have no airflow here, but in the thoracic and abdominal valves, we see lack of movement, then a little bit of movement. So this is a feature of the mixed OSA. In the past, I would say about maybe 8 years ago, until 8 years ago, the treatment of apnea was based on this metric here, apnea-hypopnea index. That is, the sum of all events of apnea plus hypopnea per hour of sleep. So we still have this classification. From 0 to 5 is normal, is physiological. From 5 to 15, mild. From 15 to 30, moderate. And 30 on, severe apnea. And in the past, the treatment was guided by this AHI. So if the patient has mild OSA, he would go for myofunctional therapy. If the patient has between mild and moderate, he would go for oral appliance devices. And from mild to severe, he would go to PAP therapy. But this stays in the past because we have other markers now that will guide us to treatment. So we don't have only AHI, and there are not only one OSA biomarker. In fact, the thing is very, very heterogeneous So we have intermittent hypoxia, like we spoke yesterday, this area here under the curve being the hypoxic burden. So this has been studied for the last 4 or 5 years and has shown to be very, very correlated with the increasing risk factors for other comorbidities together with OSA. We have the sleep fragmentation. Someone here asked me if awakenings and sleep fragmentation could be a biomarker of OSA. Yes, it could. And we also have the change in intrathoracic pressure that in research can be easily measured. Well, not easily, but can be measured. But we know now that we have different phenotypes in apnea. And this makes treatment really a challenge. So we have as biomarkers for for OSA, of course, the AHI, the hypoxic burden, this area under the curve, but other markers such as oxygen desaturation index are so important as well. The time the patient spends desaturating or saturation less than 91% is also important. This could be related to the severity of the disease. And of course, we have many cardiovascular consequences. So all of these are taken into account when treating the patient. Okay, now that you know what is OSA, what are the causes? Of course, we have structural factors. We have anatomy going on here. So this is a normal airway anatomy. So if we see here, we have a retropalatal region and a retroglossal behind the tongue region. And this, we have here the approximate normal airway volume. But if we have, for example, in a patient, an elongated soft palate, this will decrease this airway here. So this patient here can have OSA just because of the soft palate. Here we have, for example, this global pandemic thing that we call obesity or being overweight. The fact the tongue is also a muscle, and as we gain weight, the tongue also does. So we can have fat accumulation inside these muscle fibers. And we all know better than anyone that a muscle with fat cells becomes very loose. So this tongue will obstruct the airway during sleep. So we will have a shape like this and can be anywhere, okay, in here. We also can have some bone things going on here. Like here, we have different sizes between the nasal and the conium here. And we can have different lengths of all these bones that we have here that can also lead to a shortened mandibular length. So this can be one of the causes of OSA. Yes, anatomy are the main cause, but it's not the only one. So here we see in this MRI, we see here the nose and the space for a normal subject. And in an apneic one, see how this is narrowed? So imagine this subject here, he is standing to make the exam. And imagine when he lays down. So everything, when he goes to sleep, that we have the muscle relaxation. And imagine during the REM sleep stage that we have muscle atonia. So this might obstruct. Here we see the retognathia. So when we have this thin back, so in this case, if possible, they might be treated with surgery, for example. Okay, just for you to know that surgery in sometimes helps a lot. Sometimes having a surgery, of course, it will depend on the case, on the age of the patient. But for example, in children, surgery is the first option. In adults, it's not. But sometimes I have some patients that preferred to go through the surgery and use less pressure of the PAP devices, and some patients that goes through surgery and lose a lot of weight, like 20 or 30 kg, and they are free from obstructive sleep apnea. And also have patients that go to surgery and try to lose weight and still needs to use the PAP devices. But the good thing is that they use lower pressures. So it's more comfortable and the compliance is longer. And here we see the difference between this hard palate here. You see, this one is not normal, and this one is normal. So this one can be very, very related to OSA. Of course, beyond anatomy, we have the neuromotor tone. So we have all these muscles that control the airway anatomy during sleep. And we can have many of genetic or chromosomal disorders and other neurological disorders that could interfere in the obstructive sleep apnea or even central sleep apnea. For example, if a patient has a stroke in the brainstem, it will develop central sleep apnea. So some cases are denervation, fatigue, chronic inflammation, when we have muscle fiber substitution, so we have an impair in the way these muscles function. Behind anatomy and the muscle function, we might have other factors, such as genetic, hormones, pregnancy, diet, inflammation, vascular, the lung volume, and other new concepts in OSA, like loop gain, that is an engineering term that will represent the controller and the playing game, and the awakening threshold, that is completely different in OSA patients. Other cause is rostral fluid shift. So we have a fluid overload, and it looks just like a bottle when we lay down, and all these fluids will come to the thoracic area and to the neck area and will predispose OSA. So during daytime, because of gravity, these fluids are accumulated in our legs and lower limbs, and during the night it comes to the thoracic and neck areas, predisposing to OSA. So patients with heart failure, hypertension, renal diseases, venous insufficiency are at risk for this rostral fluid shift. And the new thing is that the sedentary lifetime has been a lot discussed nowadays because it also increases the risk for this rostral fluid shift. The prevalence is huge. At the same time, this is a very sad thing to see. It's an opportunity for us to work. In Brazil, at each 3 persons, 1 has sleep apnea. Here in India, we have more than 80 more than 8% of males presenting OSA, and more than 5% of the population presenting hypersomnolence. In Brazil, 25% of the males and more than 9% of females has OSA. So this is a huge thing and also a huge opportunity for all of us because it's an underestimated and underdiagnosed disease. I also tell my patients that this OSA is like a phantom, a disease that we never know that it's there, and when we know, it's kind of late. So any signs of snoring should be addressed as soon as possible. And what we have here are associated negative effects. So we have for sleep apnea an increased risk of 72% of developing type 2 diabetes, 77% of developing obesity, 30% developing coronary artery disease, 76% developing congestive heart failure, 70% stroke and TIA, 37% hypertension. So we have all these negative effects related to sleep apnea: heart attack, depression, accidents, obesity, cognition stuff, Alzheimer, diabetes, irregular heartbeat, loss of libido, heart failure, a very increased risk of motor vehicle collisions, erectile dysfunction, hypertension, stroke, and heart attack. What are the symptoms? The symptoms commonly are snoring, gasping, snorting, not breathing, fragmented sleep. They might have sleep maintenance, insomnia. They go to the bathroom a lot. So this patient tells you, oh, I wake up 4 or 5 nights to go to the toilet. Sometimes we have bedwetting, and we can also have night sweats. In the daytime, we have excessive sleepiness, fatigue, morning headaches that goes well by midday, it disappears, memory or concentration issues, mood disturbances, and decreased libido. So, OSA is an obstructive apnea and hypopnea index of 15 or more events per hour, even in the absence of the symptoms. So it's very common that a couple comes to the office and the wife says that the husband snores and doesn't live well, chokes, gasps, goes to the toilet for 4, 5, 6 times during the night. But the patient itself will say, no, that's not true. I sleep well. I sleep okay. He doesn't feel anything. He doesn't perceive anything. He has no perception of what's going on. I guess these are the most difficult patients to treat because you have to tell them that something's going on and they just don't believe it because they don't feel it. Okay? I have some patients that comes to the office just to make the wife happy. They say, I have one patient now, and he's very, very young. He's like 30 something. And he said, I don't feel anything, but I want my marriage to last. So you are my last hope of my marriage. And I said, me? I'm just going to show you the way. You are the one who's going to walk in this way. So they are happy now because he's not snoring anymore and he's wearing the PAP device. And as he is very tall and thin I think his PET device pressure was about 4.5. That are the lowest ones. So he had no problems in the CPAP adhesion. So he's complying very well with the therapy, and his wife is very happy. And I'm happy because I did my job. When the patient comes, I always like to look into the mouth to see this Mallampati classification. I'm sure people here from cardio and respiratory will know this. So we take a we take a complete sleep history of the patient and the simple upper airway examination. Sometimes we can have quick validated screening tools like the stop bang or something. And we have a look at the objective Islamic examination that we have. And we see this Mallampati classification. So we classify class 1, 2, 3, or 4. This is important for us physiotherapists because sometimes we need to refer this patient to the ENT. Okay? So if I see something going on like class 2, 3, or 4, I will send this patient to the ENT for examination and treatment. We spoke yesterday about this, and I am sure all of you had a dream about the hypnogram and me speaking about the hypnogram yesterday. So we have all these very, very important variables from the PSG. And now you're going to play a 9-minute video so you can understand it better, and I'll come back. I'll play it from here.
But first, let's take a closer look at normal breathing. Normal breathing during sleep occurs in a familiar, regular cycle. Its characteristics can be monitored in a sleep clinic. The technician usually attaches various sensors to the body. These help monitor airflow through the upper airway, respiratory effort, audible noise, heart rate, oxygen level in the blood, and electrical activity in the brain. The signals you will see and the sounds you will hear during this presentation are like the ones used to assess your breathing during a sleep study. When you drift off to sleep, most of the muscles in your body relax. However, there are exceptions, such as the diaphragm and, to a lesser extent, the dilator muscles, which control the tongue and soft palate. The diaphragm is assisting our simulated model to breathe normally. The dilator muscles, too, are at work, holding the upper airway fully open. As air flows freely and evenly into and out of the lungs, a typical bell-shaped curve of the airflow is seen. The air flows because of the bellows effect of the diaphragm muscle, which sucks air into the lungs. The respiratory bands attached to the chest and abdomen are measuring the effort required to breathe. They produce two traces, which rise and fall along with the airflow trace. Notice how the airflow and breathing effort traces move in sync. You can actually hear these correspond to the sounds of our model breathing in and breathing out normally. When you are sleeping normally, your heart rate is stable, the oxygen level in your blood remains high, keeping up a normal supply to all your organs. As this EEG trace shows, brainwave activity is as it should be during normal sleep. Normal breathing provides adequate oxygen supply so that all the organs can function effectively. You move naturally through the different stages of sleep and get a good night's sleep. You awake refreshed in the morning and are more likely to remain energetic during the day. Flow limitation. What is really happening? For those who have SDV, the muscles in the upper airway begin to relax during sleep, and the tongue and soft palate move closer to the back of the airway. This usually occurs if you are lying on your back or side due to the force of gravity, As the airway gradually narrows, it limits the rate at which air can pass through. We call this flow limitation. The airflow curve now has a characteristic chair-like shape. The middle of the curve looks flatter than it does for normal breathing. The flow at this point is being limited by the restricted airway. As these breathing effort traces show, our model is working harder to breathe. Despite the flow limitation, the sounds of breathing are still fairly normal. From breath to breath, as flow limitation continues, the oxygen level in the blood remains quite steady and the heart rate remains fairly stable. At some point, the increased work of breathing against flow limitation may lead to an arousal. An arousal is a disturbance in the sleep cycle. This may be accompanied by some movement. There is a visible increase in brainwave activity and heart rate. Each arousal has a powerful effect on your body. On arousal, our model quickly takes a few deep breaths. As muscle tone returns to the tongue and soft palate, the airway opens. The airflow trace returns to the normal bell shape, although an amplified one. This flow limitation arousal sequence may occur several times every hour. Although there may not be much change in the sounds of your breathing, your partner may notice you tossing and turning restlessly. You may wake up feeling tired. The effect on your body is strong enough to disturb your sleep and prevent you from getting the real rest you need in order to be healthy. Flow limitation with snoring. What is really happening? In many people with SDB, snoring may occur along with flow limitation. As the muscles in the upper airway relax, the soft tissue begins to vibrate when you breathe. This creates the audible sound of snoring. The tendency to snore increases when you sleep on your back. It is also affected by other factors, such as taking certain medication like sedatives, consuming alcohol, or general tiredness. Notice the turbulence on the airflow curve. Breath by breath, the frequency of the upper airway vibration increases along with the loudness of the snoring. Snoring also increases the effort required to breathe. And it can be rather noisy. Flow limitation with snoring often leads to arousal. Once again, we see why such disturbance during sleep is a matter of concern. It has a significant, visible, and measurable impact on your heart rate and brainwave activity. On arousal, our model rapidly takes a few deep breaths. As he does so, the various characteristics begin to normalize again. Whenever an arousal occurs to restore normal breathing, it interrupts your sleep. Because of the noise that accompanies snoring, most partners can readily identify this type of sleep-disordered breathing. Apnea. What is really happening? When the airflow drops to below 50% of normal, this is known as an hypopnea. If you have SDB, the amount of flow limitation you experience, with or without snoring, varies continuously during the night. As the muscles in the upper airway start to relax, the suction effect of each inward breath tends to draw the soft tissues down towards the back of the airway. Over a series of breaths, the airway progressively narrows and the airflow decreases. There are times when airflow stops completely because the airway is blocked. This is known as an apnea. Air supply to the lungs is interrupted during an apnea. Our model shows obvious signs of an apnea event. The airflow trace changes to a horizontal line for the length of time that the apnea persists. This demonstrates that there is absolutely no airflow, as our model struggles to get air through the collapsed airway. There is no noise at all, which is a particularly dramatic change if the apnea follows snoring. Our model has stopped breathing. An apnea can continue for 10 seconds or more, and in severe cases for up to a minute or longer. During this time, the heart rate drops significantly. So does the level of oxygen in the blood, since no fresh air enters the lungs to replenish the depleting oxygen. The brain soon realizes that the body is struggling. That is why an apnea always triggers a strong arousal, with severe effects on the body. Our model gasps for air, causing a sudden movement in the nostrils. Brain activity increases significantly. The heart rate after arousal is almost double what it was during the apnea. Our model's rapid breathing increases the airflow, and the blood oxygen level begins to rise again. The tongue and soft palate quickly return to their normal position as the airway opens fully. The airflow curve returns to the normal bell shape. With every arousal, your body may move to another position in the bed, but you will probably not remember waking up, even if arousals occur hundreds of times each night. Your partner is likely to notice your apneas and arousals, mainly because, together with snoring, they are keeping him or her awake. Apnea arousal cycles produce significant stresses to your body. But first, let's take a closer look at normal breathing. Normal breathing during sleep
I have edited these by myself. So here you just saw. I like this video because I think it's very easy to understand what's going on. So now that you see it, yeah. Okay, here we go. So what kind of treatments physiotherapists can explore? So the objectives are to promote proper ventilation during sleep. So we need to abolish these apnea events. We also want to promote good sleep habits So we do that through education. We need to resolve main complaint in other related symptoms. Ensure good efficacy and good adherence to the treatment, and eliminate any possible adverse effects that are related to pap therapy. So in how we do that through all these things here. So lifestyle, we are going to go through each one of these right now. So the first thing, lifestyle measures. We know that patient education is a strong recommendation from the AASM, American Academy of Sleep Medicine. So educational intervention should be given to patients prior to treatment. They must understand what's going on prior to engage treatment. And this can be done in many ways. We can just talk about it with them. We can show a very brief video. There are many of them in the internet. It doesn't need to be complete like this one that you saw, but I show a short 1-minute video to my patients so they understand what's going on. So patients should be informed about the disease, the treatment, and the consequences in short and long time. We know that besides patient education, we need to talk about them about weight reduction, dieting, and sometimes refer them to the nutritionist and having exercises as per recommendations. So here we have a very old case report that was published in Chest. It was from one patient that had OSA, and his weight fluctuated within a range of 26 kg. Because of these fluctuations, the HI, the apnea hypopnea index, also varied when he was at increased weight. So here is to show that body weight is, yes, related to OSA, but not only. As you saw, we have other causes also. And sometimes patients losing weight, they won't be free of this. They will still have it. Other thing that we have is what we call positional therapy. We have many devices like positional sleeping systems. So you see the size of these pillows. They are like pillows and body-sized pillows. We have night balance, that is a device that every time the patient turns to supine, it will do like a vibrating zzz, zzz, and the patient will turn around again. This GDS is the same thing, but it's wear as a necklace. So every time the patient goes to supine position, it vibrates. Thing is that the patient will wake. Okay, so we still have one of the things that we want to manage, that is sleep fragmentation. We also have this one, is a new one that is you stick it into here and it also vibrates. We have the belts, and like this backpack that you can wear, or these belts that will not make possible for you to be in supine position. Okay, beautiful slide, but doesn't work in practice. I have a very few patients that like to wear these things. And we don't know if just wearing these things for a patient that, for example, has positional obstructive sleep apnea, we don't know if this will really help in long term, okay? In Brazil, we talk about this tennis ball thing, and we, in the past, 20 years ago, we used to say to the patients to sew it in the back so they would not so a cheap measure. Yeah, we don't know if they really work. But here you can see hypnogram and result sheet from positional therapy. And what you see here you see the OSA, yeah, OSA. But you see that the events only happen when the patient is on supine position. So here, supine. So this is how supine, this is how positional obstructive sleep apnea looks like. We call it POSA, POSA. And when this same patient here went to wearing one of those backpack designs that I just showed you, you see that he slept on the right for all night long. So we see here the right, and had no apneas. Obstructive ones here and hypopneas here. And you see that the hypnogram went through. So this is just an example. Now let's talk about the golden standard therapy for OSA and central sleep apnea, that is the PAP device. And PAP stands for positive airway therapy. So here we have, like you saw in the video, what the PAP will make. The PAP is a positive pressure that will make the airway completely open, okay? Because it will open the tongue and the soft palate and will push the tongue anteriorly and the soft palate and here all the muscles. So we say that it will create a column that the air can pass through. So here is just a figure showing what you saw in the video, an obstructive event. And here we have a mask that comes through the nose and the mouth. We are going to talk about this just right now. But you see how the air passes, makes this column, so it's possible to breathe and to relax the muscles at the same time. So it's possible to breathe and sleep at the same time. I usually say to my patients, you have a disease that you are not able to do two very important things at the same time: sleep and breathe. So you do one or another. Okay. And what are the types of PAP devices? If we have this CPAP that is continuous, we have the APAP that is an automatic one, and we have these B-level devices that we don't call BPAP any longer because BPAP is related to a brand specifically, so we call them B-level. And we have these VAPs and the auto B-level and the servo ventilation. Okay? These two, okay, we're talking about them later. So here we see that the CPAP, the continuous PAP, and the APAP, the automatic PAP, will maintain the upper airway open. The CPAP, the pressure is fixed or automatically adjusted. So it looks like this. When APAP, the pressure increases and decreases just like the patient needs. The B-level and the servo will support breathing in lung disease and respiratory insufficiency. And the servo will stabilize breathing. So these two will breathe with the patient and together and for the patient. These two will only maintain the upper airway open and the patient will breathe by itself. It's very important for the physiotherapists to know the knowledge, to have the knowledge of the device and all the accessories to explain that to the patient. Of course, this will take some time. Does anyone here already works with the PAP devices? Just you. Anyone else? Okay. So it's very important to know the devices and to know the apps. You have to be very familiarized with the equipment, how to clean it, and how to use, and how often to change the accessories. And sometimes patients ask for different contexts. For example, traveling. How do I travel with my PEP device? How do I go out on camping with my PEP device? How can I wear my PEP device if I don't have electricity? So things like that, and we need to have an answer for all of that. So what factors can affect the pressure? Of course, anatomical factors, the body mass index. So remember the image of the tongue that I showed you. Alcohol will affect, because alcohol will induce sleep very quickly, but it will fragment a lot the sleep, and the patient will have lack of REM sleep while ingesting REM sleep stage, while drinking alcohol. PAP can also be related to nasal allergies, okay? Sleep body position will also affect pressure, as we talked, supine position is the worst. But also, mask when incorrectly fitted, we have leak, we may have lots of leak, worn out, not cleaned properly. Medications can also affect, and the rostral food chip that we just talked about. Regarding the anatomical factors, we can have many of them. So that is why having a ENT is so important for all of us. In PAP treatment, if the pressure is too low, the patient may snore, also have high blood pressure, hypoxemia. We may have residual events here, so they are not going to be solved. We are going to have some EHI. The patient will still be tired, and if the pressure is too high, they will have discomfort, lots of mask leak. They might have fluid in the ears, something that is annoying. They might have throat burning, mouth dryness. This is very, very common. Okay. And what do we do in practice? Sometimes patients do not tolerate the PAP device. So we have to do a gradual therapy exposure. And how this happens? Here I have a step by step, but you just go one step at a time, and you first educate your patient, explain to them what's going on. Then you show the mask, you show the device. I like them to try the device working without the mask. Then I put them in front of a big mirror that I have, and they will try the mask. Take it off, take it on, and see how it works. Because I think having this opportunity, they will not be afraid of it. So they will manage the mask. And then, after about 10 or 15 minutes that they are understanding the whole thing, they put the mask on and I turn on the device. And they will feel it, okay? I always start with the lowest pressure, but I have friends that start with a highest pressure like 10 or 8. So the patients will get uncomfortable, and then she will lower the pressure and the patient will feel it's okay. So we have no protocol for that. Okay, how do you do that here?
positive pressure which is supposed to be maintained at 5 centimeters of the water. So considering that, we develop it and then we put it the CPAP. For the high level, we are actually going exactly half of the above.
Okay. Yeah, that's interesting. So we have no protocol for that. You can do.
There are no set guidelines, but
Yeah, there are no guidelines for that.
in clinical practice for the CPAP, it usually starts around 8 to 10. But
Okay.
As the clinical experience goes on, most of the patients we start with the 10, and for the bi-level, it's 12 by 6 or 10 by 5.
I always start with 4, with the lowest one. I goes with 4, and then I will start increasing 1 centimeter of water at each minute, and talking to the patient all the time. And I always ask them to make it like it's going to leak, so they can hear how it's leaking, and do not be afraid when that happens during the night. So we have no guideline for that. So we can do whatever we want as long as we do what we are, as we know what we are doing. Okay? And sometimes patients can't just stand to wear the PAP devices. And then we ask them to use a little bit during the day or while watching TV before going to bed or while reading a book, wearing it while awake. Sometimes I have to ask this for 1 week, and then they'll come back to the office and we try to wear it for 1 hour during sleep. So it's a very step-by-step things until the patient can completely wear it during all night long. But what is the effect of CPAP on the patency of the upper airway? We know now from a Brazilian group that the route of delivering the pressure is very, very important. So we know that the nasal route is the best one. So we should this is guideline, okay? So we should start PAP with the nasal route. And we know that coming through the nasal, there will be a pressure column here that will push the soft palate against the tongue and will increase this area. What we know from the oronasal route, when the pressure comes into the nose and the mouth, is that it can counteract the effect of the pressure column by increasing this pressure transmission, and so you can push the tongue behind. So here we might worsen the problem. So this is the reasonable explanation why we need to start with the nasal route. In Brazil, oronasal masks are very, very common, just like US. So sometimes patients come and they ask, I want the biggest mask that you have. And I say, no way, we are going to start with the smallest one. And if needed, we can go to the oronasal ones. So I have patients in both masks because it's a very nice thing to speak about, but sometimes patients just can't close the mouth while sleeping. But I do try very hard. First the nose, and this is my last option, but still an option. So in the material that I got for you, I have this clinical decision making for PAP devices mask selection. This is from a friend of mine. I was in the examination for her PhD, so this is her PhD. And if we have a patient for PAP treatment, we have to see the sign and symptoms of nasal disorders. And if there are symptoms, ENT will look for that. And if the symptoms are not improved, we can see and might consider a nasal mask. Otherwise, we go to a nasal mask. So this is a very nice research for you to read. But always remember that the preference is always the nasal route, okay? And all the nasal symptoms should be treated before we start the pap test. So we have many kinds of nasal and oral nasal and oral masks. So this one has a triangular shape. This one just goes like a pillow. And we also have the intranasal, like a cannula. This other one is bigger. It comes into the nose and the mouth. And for some patients, and I have to tell you that I have no patients wearing this one, but we had once a case at the university that the patient had a huge problem during because of trauma in his nose. So he was able just to breathe to mouth, so we needed to use just an oral one. So treatment is very individualized. Each patient has a different treatment. So here are some examples of the brands that and the types of the masks that we have in Brazil. So this is the pillow one, oral nasal. These are the intranasal, another type of oral nasal with something coming to here. Okay, these are the ones that are very liked in Brazil because they have the tube up. So the tube, it's not here, okay? It's here, so it's easier for patients to move, and I think they are more comfortable. But sometimes patients prefer these ones here. So it's not me that choose the mask. The patient will do it. I don't sell anything in my office. I refer them to sell wherever they want to buy all these things. But I make them try at least 2 or 3, and they choose which one they prefer. They go home, they try it at home, and if they don't like it for 2 or 3 days, they come back and we change it again until they feel comfortable. Because I think the first very important thing they need is to feel comfortable to wear that. So we have these nasal pillow, the cradle, the oral nasal, and a lot of minimal contact masks. Now we have oral nasal and nasal ones that are really, really small. Okay, so some advantages of them is that they have small area of contact. Some patients with claustrophobia can wear them. They better looking, maybe more comfortable. And the oral nasal has the advantage that patients with mouth leak will wear it. But as I said, this is my last option. I do everything that I can. I'm going to show you the things that I do. Well, we also have some apps that will scan the face of the patient. And this is a patient in his phone scanning his face, the multiple points of his face. And this is called mask selector. And then the device will say the suggested mask and the size, and the first one, the second one, and the third one, if the patient doesn't like this one. So we got all these things. I'm to tell you the truth, I hardly wear this, but sometimes patients love these technological things, and it's possible for us. I think I've used this less than 10 times, but okay. We also have, and I encourage you all to read this practice guideline from the American Academy of Sleep Medicine. So this is a must-read article, and they have a conditional recommendation That is, that behavioral, as we said, and troubleshooting interventions should be given to patients at the initial period of fatigue. As you are going to see just right now, there are many, many clinical side effects of PAP. We have those related to the mask, related to the pressure, and others. So here are a collection of pictures of me and my patients trying to wear these masks. Here I have some videos that I recorded for patients in order to try to make the mouth close during sleep. So we can just put some tiny straps. We have many straps that can be used, and they are very hygienic, and you use once and throw out, and it doesn't hurt the skin. So it's a way to make the mouth close, because you inform the mucus here a new proprioception of things. Sometimes it works, but sometimes patients put that two stripes here, and then the middle stays like. And then I say cross the stripes, and then here goes like. And sometimes they get like this, pussy all the mouth. Everything we tried not to go to an oral nasal one. So this is a patient that was wearing an oral nasal mask, but he had lots of leak. But he loved to sleep in prone position. And the mask was, the pillow was always taking off the mask. No, we are still struggling with the leak with this patient. He didn't like it. He hated it. So sometimes he's a dementia patient, and when we wear the tube hook, he was taking it off. So we had to put a huge mask, very tight to the head, so he wouldn't remove it. So here is a female patient, and you see this is the intranasal mask. But if you see here, it's incorrectly placed, so there is leaking a lot. Okay. This is an under the nose mask. And what the patient did, he opened it and stuck his nose into that. So completely wrong position. You see here is lateral. So all these things happen all the time. Here we were using, I forgot the name of this thing, to make chin strap. We were using a chin strap because it's another thing that we can use, trying not to have mouth leak. But the patient tired it so much that you see the cheeks are all like these, and he started developing headaches. So all these things happen daily. This guy here was racing and having it every time, so that the teeth was hurting him. So lots of different things happens. This is very old patient of mine. I'm sorry, this is in Portuguese, but this patient came many times to the office, and we were trying her to remember how to put the mask on. So I said to her, okay, give me your cell phone. I will take pictures of each step, and you will take home. And then here, assembling the mask, and then positioning it, putting it on the head, starting from the nose, having the place here, adjusting it, fitting it closely but comfortably, and then ready, good night. So I had it printed for her and she was looking, and then we got this thing resolved. So you see, sometimes with very, very simple things, we can help them. Here are other clinical side effects related to skin irritation and lesions. So these can happen mainly when they or have allergies or tied up very too much. And then we can wear some straps that we have. We also have silicone ones in the market. Okay. So we try everything. We have many pressure-related side effects from the news, like rhinorrhea, congestion, and resistance, pressure intolerance. We have many related to mouth, just like I showed you this one. Sometimes the patients, they complain of, even in the morning, they say something is not going on just because they started the bath. So we decrease the pressure a lot, wait, see if this gets better, otherwise ask for physician help. We have to be very, very careful with face growth. Okay, so in children, we might need to use 2 masks to change it every time. In the eyes, we might have dryness or floppy eyelid, and in the ears, we might have pain or even increased pressure. So, as you see, we have many of these negative effects of the PAP device. This is another paper that I strongly encourage you all to read. This is the Brazilian consensus again. And we have a step-by-step for the follow-up of these patients. So I know this is too small, but you have this in the materials, okay, that you are going to have at the end. So you can have a look into this. And what this says is that we have set some criterion. So we set 7 criterions. If the patient fulfills the first criterion, then it goes to the second one. So it's not a protocol like you stay 1 month in step 1, then 1 month in step 2. It goes according to the patient. Okay, some patients will stay 1 week in the first step, but others might stay 1 year. So it depends how patient tolerates, and depends how is the compliance with the PAP devices. One of the interesting things that we have nowadays is this telemonitoring. So the patient uses the devices, and in the morning I can see all the variables in my computer. So I can give him a call and say, let's adjust the mask because I saw lots of leakage in this night. Or sometimes I give a call to my patients and say, what's going on? It's been a week that you don't wear the PAP device. And they go like, oh my God, how do you say, okay, I'm wearing it tonight? So it's something that you need to be very closer to the patient so they can see the difference that having a good night's sleep will make on their lives. Talking about adherence, we have this more than 4 hours per night of use of the PAP device as being the recommendation. And the duration of the use has to be more than 70% of the period. But this is what everyone says, but it really came from the US medical system. So my patients always ask, how much time I need to use this PAP device? Do I need to use it every night? And my answer, of course, you already know, is yes, all the nights, for 100% of the time. But we have some, I usually even say to my patients that they need to wear the PAP device during the naps, okay? Because we already know that we have a dose response for the using the CPAP and the functioning. So it's very, very important that they use it. But we have some different outcomes in literature showing that for excessive daytime sleepiness, when seen in a subjective manner, it can be more than 4 hours per night, but when seen in an objective manner, it has to be about 6 to 7.5 hours a night. So it depends on the outcome that you want. For memory, for example, the PAP needs to be used for more than 6 hours a night. And for cardiovascular mortality, it needs to be used for more than 6 hours a night. And for hypertension pressures, it needs to be used for more than 6.6 hours a night. Otherwise, it won't decrease the blood pressure during the night. So we have different outcomes and different hours according to these outcomes. Well, just for you to know that these exists, but of course, in Brazil, myofunctional therapy is for speech therapists. So we even have some exercise that you can make on your cell phone. So myofunctional therapy, according to this literature review from Cochrane Library, it improves a lot in some patients. So we need to know what kind of patients we are sending to the speech therapies for myofunctional therapy. So it's a set of exercise that needs to be made every day, maybe 2 or 3 times a day, and can decrease the intensity of the USA symptoms and daytime sleepiness, and can be performed only with myofunctional therapy or combined with PAP therapies. I think it's in children, they didn't have such good outcomes because compared to nasal washing alone, adding myofunctional therapy resulted in little or no difference. So myofunctional therapy is usually used in adult patients. I asked someone, I just don't remember who it was now, about the Professor Magini. I asked him about the dentists here in Delhi. Because in Brazil, another thing that is very common, and we work together a lot with the dentists, is that some patients can wear these intraoral devices. So this is a device that they put for sleep and take it off when they wake up. And the idea is the same, but the mechanism that it treats obstructive sleep apnea is different. So it pulls this forward, and we have the space for breathing. So sometimes patients just don't tolerate the PAP devices, and then we ask for help for the dentists colleagues, to see if they can wear it. But of course, they have evaluation, they have a lot of objective examinations like TC to see if the joint here can be pushed with this intraoral device. So you must know that this is an option. We also have this thing that, to tell you the truth, I never saw a patient wear these. These are devices that protrude the tongue. Very, very annoying. I couldn't wear this. I even never tried them. but some dentists in Brazil prescribe them. We have a group in Rio de Janeiro that are doing a lot of research in respiratory muscle training. So if any of you wants to do research in this area, I can put you in contact with them. They are a very nice group of research, and they are having good experience having this muscle training with these mild and moderate OSA patients. Okay, this is from Torres Castro from Chile, a group in Chile that also studies this. And this consists of training the surrounding collateral respiratory muscles. So sometimes it helps a lot alone, and sometimes it needs to be combined with PAP devices. Of course, as we have said before earlier today, exercise and weight loss is a must. So I strongly encourage all my patients to exercise daily so we can have impact on apnea, sleepiness, and increase the sleep quality of these patients. Other things that are going on that I think you must know is that we also use the TANs. You see, physiotherapy and TANs are all together. And we also use the TANs as external stimulation here in the skin for hypoglossus and genioglossus stimulation. And also we have this device that will deliver these stimuli into the tongue. But the thing is that sometimes you strain the whole tongue and you get worse apnea. So this is not something that physiotherapists do in Brazil. It's related more to the speech, this one here, speech therapists. So these are new things that are coming on, and a lot of research are still needed for us to use in daily practice. Okay, so let's talk now about central sleep apnea. It's going to be shorter, but also very, very important. So just let me have software here. No, I don't assess for that. I send them to the ENT. So you see, we are always working together, other healthcare practitioners. So it's great because you learn from them. Okay? So, central sleep apnea is characterized by a temporary loss of the production of respiratory stimuli from the pacemaker in the pontomedullary region of the central nervous system. There is an absence of central stimuli that will result in loss of movements in the main ventilatory muscles, the diaphragm, the thorax, and the abdomen. So we see here a cessation of the flow that's usually more than 10 seconds, and it is without thoracic and abdominal effort. Can be terminated by an arousal or associated with a desaturation. There is no snoring during the event. There is no increased respiratory flattening of the flow sign compared to baseline, and there is no paradoxical movement during the central event. So this is a disturbance in ventilatory control. This can be a disturbance of the central controller, here explained in this picture, or the effectors, the muscles, or even in the sensors. So it can be a combination of them. So here is how things get harder, because it can be a combination of that. Usually, we start treating the patients, and later we will have a cue of which one of these components are involved. So here we see some polysomnographic patterns of central sleep apnea. What we see here is what we call the Chine-Stokes breathing, that is very, very common in patients with heart failure. So we have an instability in this ventilatory control. We have this increase and decrease pattern that we call crescendo decrescendo pattern. Okay? And here we have the apneas. So this goes on and on and on. It's a pattern through the night. Here we also might have in stroke or in drug-induced patients, we also might have this instability in the control of the ventilation, leading to a central sleep apnea. So I want you to remember that central sleep apnea is related to any comorbidity. So have a look for your patient for heart failure, stroke, pulmonary hypertension, chronic renal failure, chronic opioid use, or OSA. It can happen together, as we saw. So some clinical characteristics of patients with sleep apnea, they can demonstrate daytime sleepiness, morning headaches. Sometimes it's combined with OSA and then can snore. They might have any kind of respiratory failure. They might have pulmonary or polycythemia. And when they are combined with obstructive, they might present all the obstructive symptoms. They might also have insomnia and awakenings and things like that. So we have four main kinds of central sleep apnea. The Chine-Stokes breathing pattern that I just showed you, a drug-induced one that is mainly induced by opioids, the one that we spoke yesterday, I'm sure you remember, the treatment emergent central sleep apnea, and idiopathic one. So this is the crescendo pattern of the Chine-Stokes breathing. Here we have the apnea. Here we see the lack of thoracic effort, and here the lack of thoracic abdominal effort. So here is how it looks like in a window, in a PSG window. And we also have this automatic tracking of the central apnea. So the software will show us where this is happening. Here we have a split night polysomnography result sheet, and we see that in this first diagnostic part of the polysomnography, there were no baseline central apneas present. And then when we start the PAP device, the central apneas start to present. So this is typical of treatment emergent central sleep apnea. Sometimes we have this idiopathic one. So this is an example of a 27-year-old boy, non-obese, that presented with mild daytime sleepiness, nocturnal awakenings, and unrefreshed sleep. So what we can see here is in the airflow, we see that it stops many, many times, and that we have the lack of effort on the belt, chest, on the belt here. This one is the thoracic belt here, okay? And we also have these saturations all the time, marked in these blue squares. So what is the treatment for them? This is a disease that we need a physician to get up. We treat the underlying disease, we go for PET therapy, and we have some complementary ones. So just like obstructive sleep apnea, we also have positional therapy for central sleep apnea. Because of its association with airway instability, and we lack the understanding of this, the complete understanding of the disease. But we know from many studies that the lateral position, see, you sleeping at your side, will attenuate the central sleep apnea, mainly in patients with heart failure. So sometimes we have specific positional central sleep apnea. Okay? The mechanisms are related to reduction of hypoxemia. I have now a clinical case that I combined both, so we can translate and understand everything that we saw until now into practice. So this was a patient of mine, 59 years old. He was a physical educator. I saw him for the first time in June from 2022-21. He was referred to me by his neurologist, and his main complaints were tiredness, fatigue, and excessive daytime sleepiness. He said he had lack of memory and concentration, non-restorative, and fragmented sleep. He said he had poor sleep quality, and he complained a lot of nocturnal spasticity. He had a stroke in 2014, and it showed a ischemic and an hemorrhagic stroke. The stroke happened at 11 o'clock in the night when he was napping. And the NIH severity scale was 20. The modified ranking scale was moderate to severe disability. And he also presented some signs of Valerian degeneration. He used to work. I remember he worked for about 20 years as a shift worker. He had a congestive heart failure. The ejection fraction of his heart was less than 40%, and he was on medication for hypertension and prostatic hyperplasia. He had a BMI of 24. His neck size was 34.5. The Malampari classification was a second class. He had considerable sleepiness in the Epworth sleepiness scale, and he was an hemiplegic in the left side because of the stroke. He had no routine, and his sleeping time was, he went to bed about 1:30 in the night or 2 in the night. He said he didn't take long to sleep, usually woke up at 8 a.m., but stayed 2 more hours trying to sleep a little bit more. He had lunch about 4:30 p.m., which is in Brazil like evening tea. We usually have lunch at midday in Brazil, and lunch is the main meal. Okay, it's the most important meal. So And he took a nap after his lunch for about 2 hours or more. So by now, I know you're all are thinking about many things that already can be treated and discussed with this patient. And he usually got his dinner for 11 in the evening. He said he had to hurry to the toilet during the night for 2 or 3 times, and he was on many medications like this for all his diseases. But as he was a physical educator, he knew the importance of exercising, and he exercised daily, going to Pilates and academy. He was also into the neurological rehabilitation. His wife was a neurological PT, and he also was into speech therapy because of the sleep. And right after the stroke, he had some sessions of psychotherapy, but he was at that time not going to that. So the patient came to me with a PSG, and what we saw is that he had many arousals. So the arousal index was about 28 number of events per hour. He had a moderate OSA, 26 events per hour, being 17.9 of obstructive ones, 6.7 events of hypopnea, and 1.4 of central. So he didn't have any central sleep apneas, only obstructive ones. But he had a very important desaturation. The nadir of the saturation was 68%. And he spent about 45 minutes of the night below 90% threshold. We start then the home titration with the automatic pap, and the physician asked me to put him between 4 and 10 centimeters of water. The initial pressure was 4. We used no pressure relief, but we used the ramp for 20 minutes. And these are his first days. So what we can see here is the pressure. He was on medium 5.8, and he had a maximum of 10.2. He had some very punctual specific leak here, as we can see, but mainly of the time the leak was within average. But the respiratory events decreased only from beginning to now, only for a half. What I saw, remember the central apnea that was 1.4, now was 6.1. Here we have in green the days that the patient used more than 4 hours, and in red the days he used less than 4 hours. So his dotted line here is to mark the 4 hours. When I opened his flow curve analysis, I saw the chain-stroke breathing, this crescendo and decrescendo pattern all over the night. So this was what got my attention. He was having like 31, 40 minutes or 40 seconds of sleep apnea, even on PAP device. But the first thing that was very, very hard with this patient was choosing the mask. So the first thing, we tried the nasal route. There's no sound. So this is the patient trying to put the mask on. And this one he chose because it was easy for him to use just one arm. And this one has a little hole in the here, as you can see here, the little hole. So he was able to feel it and adjust it by himself because he didn't want to depend of his wife. And he was looking for functional independence. So while titration this patient, he had some difficulties at the first days. It's normal. He had a little bit of phobia of the pain, but we talked so much, and we had some 5 or 6 sessions about education. Then he had a fear not to wear it and have another stroke after we talked. So he started wearing it, and he was one of the most compliant patients that I had. His wife, he hated to be dependent on his wife, and with the PAP, he improved it over the time. So as you see here, this is a very long history, and we've been together for so long. But as you see here, the EHI wasn't getting much better. After the titration, I fixed the pressure in 5.8. I discussed that with his physician. But what we saw here was that central index of the apnea, you see, it was 1.4, went to 6.1, and then was increasing to 12.8. So this is typically treatment emergent central apnea in a stroke patient. The Chine-Stokes breathing also increased a lot. So we discussed it again with the physician, and as nothing was getting better, it was remaining the same thing, and the months were passing by, we thought to perform a high resolution pulse oximetry, and we saw that saturation was 89%. Yet he was feeling better, he has no daytime sleepiness, he reduced his afternoon nap. The cardiologist changed the medication, reduced the medication, and we went to fixed pressure on PAP. Yet, when we reached the month 5, it didn't get better. In fact, it got worse. So I had to reduce the pressure, but it was worsening all the time. As you can see here, the Chine-Stokes breathing was increasing, alarmingly increasing. So again, I talked to the physician. The physician asked me to increase the pressure and wait for 2 months as he was going to change medication. We did that and nothing happened again. So the patient was basically at the same central apnea going on month 8 of treatment. So we talked about, and the physician, the cardiologist, started many investigations, and what we saw is that he was on heart ejection fraction that less than 35%. And this was the thing that was contributing to worsening of the symptoms and increasing of the central events, all at the same time. So I had the brilliant idea to ask the physician to have a split night study and with the PAP. So what I wanted here was to see if the PAP was working or not. So I asked the physician and the lab technician to make the first part baseline with no PAP, and the second part of the exam with the PAP, with his PAP, with the pressure that he was using. And we saw that
There were no change in the breathing pattern with the PAP device, with the pressure that we were using. So we sat together, four of us, me, the cardiologist, the neurologist, and the patient. We discussed what was going on. And then the cardiologist decided to start this medication that is for central sleep apnea. And he started it in very low doses. And then we were able, you see, the EHI finally was 2 and the central index 1, 0.1. But he was using PAP device. So this is an example of how we work together. And the work is not only from the physiotherapist. We have to be together with all health practitioners on behalf of our patients. Here is, I just brought this because I think it's very interesting. This is the biphasic sleep that this patient has. So each one of these lines here is representing one day. And we see that the patient has nighttime sleep here and afternoon sleep here. So this patient has 2 periods of sleep. So approach as now obstructive apnea was resolved. Treatment emergent central sleep apnea was resolved. We were looking to resolve this sleep. So I want him to sleep for just one period of night. So you see, this is a patient that is with me for about 5 years, and we still have a lot to do. So I have many reading materials on this disease for you all, and I'm happy I finished on time. Thank you very much for being here. I haven't actually gone for.
After got glasses.
Sorry,
To
I
check
didn't
the
hear.
carbon dioxide and the
No, we
baseline of the
haven't.
sat-
No, we
particle.
haven't. Yeah, no, we haven't. You see, I come from neurology background, so this cardiology. If you were here, maybe you would ask the physician to do that. But it's a great idea. Thank you for your input.
Why I'm saying like this, because what I feel in that particular patient, the fall of the saturation or the partial pressure for oxygen was constantly being low for a long period of time. And when we were providing with the high positive pressure, it was actually correcting the hypoxia, and the patient wasn't hypoxic, right? That could be the reason for the central apnea.
Yeah, but see, here is just a very short period of the treatment of the patient. See, I wasn't able to bring the whole picture, so I brought just some insights of this. And I'm sure we did the right thing because I was together with the neurologist and the cardiologist. So I think that's because of it. You just see a part of it, you don't see the entire thing going on 4 years of treatment. Okay, thank you. Yeah, perfect. Good. So we have a break now?
Thank you so much, Dr. Christina, for that detailed and thought provoking session on sleep respiratory disorders. The lecture provided us with a very broad framework and improved our understanding of the topic. Please join us for a tea break and take this time to refresh yourselves and get ready for our next session, starting promptly at 11:45 a.m., where we will explore yogic intervention for sleep by Professor Manjari Tripathi Ma'am, a distinguished neurologist and academician at AIMS, New Delhi.
Thank you. Please try to please take your coupons with you.